Okay, welcome everybody. This is another edition of SEVA VentRounds, and as always, these are the disclosures for Eduardo and myself. Ground rules, as always, this is a recorded session, so keep your microphone muted unless you want to say something. If you want to comment, you could always use the chat function instead of doing it verbally. And at the end, Cleveland Clinic employees get CME, so stick around for the code for that. Now, today I want to talk about one of my most favorite subjects, and that is the use of simulation-based educational training procedures. And specifically, when we talk about patient-ventilator interaction principles and how to learn them, which is mostly what VentRounds is about, there are a number of problems. And one is that almost any ventilated patient can be optimized. You can walk into any ICU anywhere in the world, pick any patient and do something to help them. But any vent changes exposes the patient to a risk of mistake. And hence, if we can learn with a simulated patient, we avoid that risk. Patient-ventilator interaction patterns have been well described, but each breath in that pattern may be different. And so if there's a lot of variability, it makes learning these patterns more difficult, which again is the value of simulation. You can have every breath look exactly the same. Or of course, you can also introduce some variability if you want more complex simulation. Now, managing problems that you identify assumes that you know specific ventilator knobology, but lack of familiarity with a specific ventilator, if you're actually putting your hands on a machine and looking at the waveforms, can impede your learning of these PVI waveforms. So again, if you have a simulator, it's generally a generic type of ventilator, simple modes, and simple controls that everybody is familiar with. And then finally, actual waveforms on real patients, as we've seen time and again in VentRounds, are often contaminated with noise, and they look horrific. They're very difficult to understand. So noise makes pattern recognition in the early stages of learning this skill, makes things so much more difficult. So again, one solution to all of these problems is to use simulations. That is a patient ventilator simulator. So almost any ventilated patient can be optimized, but there's no risk to the patients doing this. So patient-ventilator interaction patterns have been described, as we said, and simulators are run or they're designed with strict mathematical reproduction of these patterns without any noise. Again, like I mentioned, they're ventilator agnostic because they're you can think of them as generic ventilators. They're simple pressure, volume, and flow waveforms and simple controls for pressure control and volume control settings, and simple settings for the patient, underlying patient conditions, which we'll talk about in a little bit. And again, as I said, with simulations, there's no noise. You get the same breath shape for every single breath in the pattern, unless you specifically program the simulator to do something different. Now, if you have taken the SEVA basic program, you will be familiar with this simulator that we provide for you. This is a simulator that was programmed in Excel, Microsoft Excel, and you download it onto your computer, and you get this sort of keyboard pattern here so that you can do a bunch of things. You can do pressure volume control continuous mandatory ventilation, pressure control continuous mandatory ventilation, and pressure control continuous spontaneous ventilation. And basically, volume assist control, pressure assist control, and pressure support. And then these other buttons show you the equations, the mathematics behind the simulation, various resources, a glossary of terms, different models, certain exercises, and a lot of things you can do. But right now, I just want to focus in on these buttons here that show you what the simulator can do. So if you press volume control, for example, you get a screen that looks like this. And on the left-hand side, we see some settings here with a lung model, which is basically the compliance and resistance, with some calculated values, for example, for elastance and time constant. And then you have what's called an effort model. And these are the parameters of the PMUS waveform. So the amplitude of the muscle pressure, the duration of the effort, and how long it before the start of the breath it can be started. In other words, a delay. And you use that, as you'll see in a minute, to generate some synchrony problems. And finally, we have these generic ventilator settings. Because we are in volume control, you can pick either a square or a ramp flow waveform. And here you see we have a square or a constant inspiratory flow. Then you can pick the value of that constant flow, the tidal volume, the frequency of the breaths, PEEP, and a pause time. In this case, we have a short pause time. And then finally, down at the bottom, there's a whole bunch of calculated values. These may or may not be of any interest to you, but we have used them for research purposes. I think all the way at the bottom, you'll actually find some values for work per breath and power. Now, this is just an example of how the effort model can change these waveforms. This red line represents the PMUS waveform. Here you see there's no trigger effort because the maximum value of the PMUS is set to 0. Here we have a small trigger effort with no delay relative to the start of the breath. So you can think of that as triggering this breath, and a small peak PMUS pressure. And you can see, as we've shown before many times, that if you're in volume control, any inspiratory effort will deform the pressure waveform in a proportional amount, with no effect on volume and flow, because, again, this was volume control. Here we see the effect of delaying the effort till well after a machine-triggered breath. And what this has done now is it's clipped off the peak inspiratory pressure and it's distorted the plateau pressure. Here is a pressure control breath. And here are the ventilator settings here. Inspiratory pressure target above PEEP, frequency, inflation pressure time, the inspiratory time, and a pause time also. Here again, the patient is passive, so you get these classic waveforms, constant pressure, descending, decaying exponential for flow, and the increasing exponential for inspiratory volume. And again, these are ideal waveforms and no noise from any external event happening. Here again, we see a late in the breath inspiratory effort. And we see what has happened here is that because it's pressure control, it does not affect the pressure waveform. Now, again, these simulators, and this simulator in particular, is strictly a mathematical model. So unlike real ventilators, this is a perfect pressure controller. So no matter what you do for inspiratory effort or changes in the mechanics, you'll always get exactly the pressure waveform that you have programmed in with the ventilator setting. But where you look for the effect is down here in the flow waveform, which you can see this big hump, this increase in flow because of the increase in the muscle pressure. And we have an increase in the tidal volume as well. Although it's a little bit harder to appreciate the change in the slope of that volume waveform. Now here we have the pressure support mode. And again, the same ventilator settings. In this case, you can set the flow cycle threshold because there's no set inspiratory time. Here we see a small inspiratory effort and a moderate tidal volume. But if you go to a larger trigger effort, you get an effect on the inspiratory time and you get a much larger tidal volume. So all of these things are easy to play around with. You can get a feel for how changing lung mechanics will change the pressure and volume and flow waveforms, and how changing the effort model will also have an impact on either the pressure waveform for volume control or the flow and the volume waveforms for pressure control. And this is a relaxed, low stress, low risk way to learn a lot of things about patient ventilator interaction. Now, that's a very simple model. And there are and it's a free model that you can get as part of the SEVA course. There are much better models available, and they live on the internet. And this is probably the best one I've seen so far. It was designed by Tom Pirano, who is a Canadian respiratory therapist and a programmer, a really smart dude. And he's put a lot of work into this simulator that you can get to. I'll show you at the end. But it's rtmaven.com. And the interesting thing about this is that it's dynamic. These waveforms are animated. They scroll past, unlike the previous one I showed you, which was all static. This looks just like a ventilator display. It has a lot of interesting features. So, for example, on the left-hand side, you have the ventilator settings. You can set the mode, and I think there's 3 or 4 different modes, or simple modes, like the ones I just showed you. These modes are actually given a mode tag, like we use in the ventilator mode taxonomy. So Tom has accepted this as a way to display the names of these sort of generic ventilators and generic modes. And at the bottom, he's done something really interesting. He's put in these little buttons that are preset patient-ventilator interaction problems, and we'll go over that in just a minute. If you look a little bit more closely at the ventilator settings section, you can see that these are the vent settings, these are the measurements, and I like the way he's distinguished between settings and measurements. These are the different modes. You can get volume control, pressure control. These are basically CMV modes. PRVC, that's a CMV mode, pressure support, and PAV. So these are 2 CSV modes. So it's pretty impressive that he's actually programmed PAV in here. This is a lot of mathematical work behind the scenes. If you look at one of the drop-down menus, you get the patient scenarios. And here you can see there are preset disease states. So if you don't know what to put in for resistance and compliance, then you can click on one of these things and simulate the mechanics of different patient diseases. Or, of course, you can always adjust whatever you want. There are some really nice details here, like you can add the recruited volume that talks about how the lungs will respond to PEEP. You can put in airway opening pressure, which is, I should have mentioned that Tom is associated with the Toronto Medical Group, who's published a lot about airway opening pressure and how that can affect your measurements. You can also program a stress index, which is an index of either overinflation or recruitment during inflation. In other words, over PEEP or under PEEP. It's one of the tools you can use in certain cases for setting optimal PEEP. Over here, we see a bunch of parameters that you can set to adjust the inspiratory effort. Patient doesn't have to be actively breathing, but if it's enabled, then you can set the PMUS in terms of its amplitude and its rate and those types of things. Now, just to give you an idea of how you can use this for yourself in learning, or you can use it as an instructor for your students, I have clicked on one of the buttons at the bottom, which are now hidden. These are the preset synchrony problems. So looking at pressure at the top and flow in the middle and volume at the bottom, what synchrony problem do you see? And Eduardo, you're going to have to advise me if anybody comments.
Got it. So far, no input. Well, they put some input, Rob. Perhaps you can comment a little bit on the reality versus these equations. Can you comment about the equations and the how truth are these simulated waveforms to what we should be seeing on the ventilators? That's a common thing that we hear, saying, "Oh, that's a computer; it doesn't represent reality." Can you talk a little bit about that?
Yeah. Well, as I said, these are ideal waveforms, meaning this is an ideal volume control machine or an ideal pressure control mode, which means that you don't get any of the distortions that you would normally see from, let's say, tubing compliance or moisture in the circuit, so there's no noise and no vibrations. And I don't remember whether or not there's cardiac oscillations in this model or not, but in this case, we don't see any. But this is, you should think of this in the same way you think of learning ECG patterns. So when you're learning ECGs, you get these waveforms in the textbooks, and they're more or less ideal waveforms. They don't have a lot of noise. They're designed to show you specifically one type of problem. And that's how these waveforms work. So in this particular case, you see the first breath is a volume control breath with a constant inspiratory flow. We have a nice peak pressure as we'd expect, the initial rise due to airway resistance, and the slope is due to the elastance, and the patient passively exhales. Everything looks good. But this second breath, something's wrong, right? So what we're seeing is that there is a drop in the peak pressure that's getting clipped off, and we're also getting a clipping of the peak expiratory flow. This is sort of an ideal example of one particular synchrony problem. Did anybody come up with a reason, Eduardo?
Yep.
What you got?
There's a PMOS is present, early cycle, and then an early trigger. You may want to differentiate those two as you go through.
Okay. This was the reverse triggering or early triggering. Okay. Why is it an early trigger? Because it's a machine trigger of the inspiration, and then a patient's inspiratory effort comes in somewhere about the middle of the breath, and you know that it came in because the only thing that can make the pressure go down is the PMUS pressure going up. Also, the PMUS has bled into the expiratory phase. Now, how can we check the reality of that, the truth of that? Well, this simulator lets you plot PMUS, which you wouldn't see on a ventilator, but you would see on a simulator like, for example, the ASL 5000 or other simulators that give you PMUS. So now in red, we see this inspiratory effort happening here. And we see that it started in the middle of the breath and continued till well after the ventilator cycled off. So this is causing this clipping, and this part of the inspiratory effort is causing this distortion. Any comments, Eduardo?
No, yeah, I would just highlight that having a marker that this is a patient trigger breath versus a machine trigger is very useful, but I think that there is enough information on the waveform for you to be able to come to terms with that. So especially on this example, in particular in this example in which you have a breath that is completely passive with a nice step up and then the gradual rise. And you can see on the next one, in the next breath, that it starts exactly the same. So if you would grab, I don't know, a piece of paper and occlude the image that you have there, you would then see that it's identical until you get to that point in which it changes, and it would tell you, yep, this was a machine trigger, and then there's evidence of PMOS. And then this is a very common item, Rob, that we tend to look at the pressure waveform during exhalation for aberrancies. And in this example, actually, it's very nice how you barely see a little depression on the pressure waveform, but it's very evident on the flow waveform. And so just the fact that you have to shift when you're in volume control from looking at the pressure waveform to the moment that you go to exhalation to look at the exhalation waveform, at the flow waveform.
Yeah, and the reason for that is in volume control, the distortion is in the pressure waveform, but in pressure control, the distortion is in the flow and volume. And the expiratory time is all pressure control. So in fact, the ventilator is doing volume control for inspiration and pressure control for expiration. And that's why your eyes go here and here. Also, there are trigger flags, but there aren't any patient-triggered breaths, so there's no flag showing up. Okay, so here's another one. This is another button preset that I have selected. I didn't have to do anything. I just set the ventilator, hit the button, and boom, we get this PVI problem. So what do you see now? And again, these little triangles are showing patient-triggered breaths, this little red triangle here, just like on a ventilator. Not any ventilator in particular, but on the simulator. So again, we're in pressure control. So we want to look at the flow waveform for evidence of PMUS. We could also see it in the volume waveform. And what are we seeing here? What's going on?
So there's a stream of failed triggers coming through. So everybody, you've had 4 answers, and all of them said failed trigger, Rob.
Yep, and where you see the failed trigger is in the expiratory flow curve. We see that it's not a nice exponential. It gets this little hump in here. That hump comes from PMUS. And I will point out that oftentimes in the literature and on some simulators, PMUS is shown as a negative value. COM allows you to display it as either as a negative PMUS as shown here or a positive PMUS. You can hit one of these settings and this will invert the way it really is, because PMUS is mathematically always positive. But nevertheless, what we see here is we have a short PMUS, the inspiratory effort here causing the triggering of this breath. And this is pressure control CSVS, which is what? Pressure support, right? So flow decays down to whatever the flow cycle setting was for this thing, and then it cycles off. And then in the middle of these two breaths, these two spontaneous breaths, we see an inspiratory effort, a very slight distortion of the pressure waveform, but a large distortion of the flow waveform. But what do you notice? It doesn't go through 0. So if it doesn't go through 0 and it's flow triggered, there's no possibility that the ventilator knows that you did anything. So you have a failed trigger effort. And that's how you can prove it, again, by looking at the PMUS. But even if you didn't have PMUS, you can see it in the flow waveform. Let's see if we can get another one in.
I was going to just comment, Rob,
Sorry.
an important thing here for the team, especially as I know that there's a lot of educators here, is and people that are training to see this even better, to get to read the PVI, is the benefit of having a simulator such as this one or the prior one is that if you know how the waveform looks on a passive and then you activate the PMUS, but you don't see the PMUS, the red line that you're seeing there, then you can see where it starts and where it ends. That's a key item of your visual acuity to learn how to do that. So now that you have, then you can add on the PMUS and see how that changes the waveforms, so that you can do a contrast and see if your eyes were looking at the best one. So it's a way of practicing yourself with the truth on what's there.
That's very good. And the distortion in the waveforms is often reflected in terms of its shape by it's reflecting the shape of the PMUS. So in this case, PMUS is the same shape as this distortion in the flow waveform. Okay. One more. What synchrony problem do you see here? We are now in pressure control CMVS, or pressure assist control, if you will. So again, if we're in a pressure control mode, your eyes should go to the flow waveform first. You can confirm it on the volume waveform sometimes, but it's very sensitive in the flow. We see that every breath is got these little red triangles, which indicates that these are patient-triggered breaths. We also see a period of zero flow, which means that these are time cycled breaths, right? And the inspiratory time for every one is exactly the same. So these are all clues for what kind of PVI problem might be happening. We getting any responses, Eduardo?
Yes, and everybody's getting it very nicely. All of them are late cycle.
Late cycle. So looking at the the flow curve, we see that it's not a nice decaying exponential. It's bumped up. It can only be bumped up by inspiratory effort. But we see that the inspiratory effort goes away because the flow goes to zero. So that means the patient had an effort starting around here, it looks like, and it ended around here. And then, even though the patient said he wants to exhale, the ventilator didn't let him exhale until way over here. And again, we verify this by turning on the PMUS waveform, and it happens just the way we said. Patient triggered, had a relatively high inspiratory effort to about the middle of the inspiratory time, which is distorting this flow and making this volume go up. Then the patient suddenly relaxed, flow goes to zero, and the ventilator doesn't turn off the inspiration until way over here. So that's late cycling. Excellent.
I would comment if you go just to this image, a common item. Remember, this is idealized waveforms, and so an important thing on late cycle, sometimes we think you're going to see an increase on pressure during the end of inspiration. And that increase in pressure depends on the ventilator that you're using or performance characteristics of the ventilator. Some ventilators close the valves, actually. Some of them keep them open. So sometimes this may lead to a concern of, is the patient doing actually effort to exhale, or is this just relaxation of the muscles? So this is a little bit more nuanced. And as you start seeing the waveforms, the reality, this is one of those that has a lot more noise than what this one shows there, Rob.
That's correct. Although, you know how we have talked before about how you can do a plateau pressure,
Yep.
inspiratory hold,
Yep.
and it's either the same or less or higher. You can do that on the simulator. You can demonstrate those things.
That's right.
You can do a lot of things that we don't have any time to talk about, but it's all in here. Virtually everything that we talk about in vent rounds can be demonstrated with this simulator. Anything else?
Nope. There's a question here. Is there a way in the SEVA to move the start of the inspiratory waveform to the right so it can be seen away and independently from the zero vertical line in the CMB modes? This is actually, this has been a request in the past, Jorge, so good that you bring it up. Rob?
No, that simulator is way simpler than this simulator.
Yeah.
You can't do that. What you can do, however, is you can play around with the frequency so that the very first breath will start at zero time, but the next breath will start sometime, sometime after the first breath. So you can see it both ways. But the first breath always starts at time zero.
It's an Excel thing.
No, it's a limitation of my programming skills and time. So if you want to see something more realistic, you want to see something that's animated, dynamic, like a simulator like this, and then you can see anything that you want to see. Now, there are other free online simulators, and one of the ones that stands out for us is this VentSim by Dr. Safadi. It also has simulated dynamic waveforms like you see on the ventilator, but it throws in blood gas simulation as well. So as you make changes in the ventilator settings or in the patient's disease conditions, you will see a simulation of what happens to oxygenation and ventilation. Now, I don't know how accurate that is, and it probably doesn't matter. It just indicates a direction. So, for example, if you decrease the rate, then the CO2 is going to go up and the pH is going to go down. Those are the kinds of things in general that you see with that. So I don't know to what extent these blood gases have been validated, but again, for our purposes, they're quite good enough. I will also point out that Hamilton has a medical college online that's free to anybody. All you have to do is go to there and set it up. You can see a simulation of virtually every ventilator that they make. You get animated waveforms like we've just shown you, and you get blood gas simulations. So you get like end-tidal CO2 and saturation, and you can change the patient's disease states. And so there's a wealth of information, but these are not generic ventilators. These are specific to Hamilton. But they have done a lot of great work, and I believe it also will run on your phone as well. So with that, I'm going to conclude. Eduardo, are there any take-home messages that you want to convey?
Evidently, there's free and others that are not free. The ones that we have highlighted here are free. The one by Tom Piraino and Safari and the Hamilton one, those are all free simulators. There's others out there. This is just a sample of what's available. We're again not endorsing or I mean, we're just sharing what's out there and what we liked and didn't like. Importantly, there is also gaps. I hear you, Jorge. If there's a volumetric capnography simulator, not to my knowledge. There's websites that have capnography waveforms, but not necessarily volumetric ones. Rob, do you know of any?
I know the ASL 5000 by Ingmar tried to simulate that, but I could never get it to work. So other than that, I don't know. IMT Medical just came out with a Alveo patient ventilator simulator. And what it is basically it's a hardware box. It's a relatively small hardware device. You connect it to a real ventilator, and you can get blood gases. And I don't think it has a volumetric CO2, but you get indications of oxygenation and ventilation and even hemodynamics.
Right.
So that is the ultimate simulator on the market that I am aware of right now that can be used again with a real ventilator.
Very good. There's the QR code. So for those that are CCF, please go ahead and scan and apply for it. Do you have any other slides, Rob? And do send us your waveforms. Either mainly, I actually have to remove the Twitter part. I'm barely using that part, but please do send them to my email over here. And then please, if you're interested in attending in September, I think that we have only a few slots left on September, so hurry up and sign up for it. All right.
Okay, thank you all for attending.